All right, I'm ready when you guys are with for any questions you might have.
Okay. Just trying to figure out. What question to ask? I think I have a couple of questions.
Sure.
Actually, one of the questions is pertaining to the Respondus practice exam.
Okay.
Do you want us to complete the practice exam at the location that we're planning on taking the exam?
Nope, doesn't matter. You don't have to take the test in the same location every time. It's just a opportunity for you to kind of see how to do it, and for me to make sure that you're like, the most important thing is so I can see the environment.
Got it.
And, so yeah, it doesn't matter where you take it.
Okay. Yeah, because I would like to take it at home, but I have a 6-year-old. I think you can probably see him right there.
Oh, yeah.
So he's running around most of the time.
And that's okay. If it's going to distract you,
that's the only thing that I'm worried about.
Yeah.
Is I don't want there to be any distraction.
No, so. I understand that. I'm sure you guys on a lot of those videos, the early videos I recorded, my son used to come in and out of the room, and so I would be trying to talk to him and not stop talking to you guys, and so you could hear me kind of hitch. So, but if you are at home and he comes in and even asks you a question like that, I understand. You can't really control that. So,
right.
Yeah, that's okay. So whatever's easiest for you.
I'll take that into consideration then. I'm going to try to do it at my local community college library.
Okay.
Because I live in Orange, and I'm taking a class at another community college, so I'm just going to try to
do it there.
Use their space.
Okay. Yeah.
And see how it goes. I'm hoping I don't think their Wi-Fi is spotty, so I don't know. Hope it's okay.
It should be okay.
That was one question that I had.
Okay.
And then for the material, I had a question. I think it was the Unit 3.
Okay.
I haven't completely gone through all of the videos yet.
Right.
But okay, what slide number is this?
I'm gonna pull mine up.
It's on slide 15.
Okay.
Of Unit 3, the partial. Is it agonists?
Oh yeah. Okay. Partial agonists.
And you probably describe it better in the video, but I haven't gotten to your video yet. I've just been looking over the slides.
Okay.
Usually I watch your videos while taking notes on the slides.
Right.
But this time I just read the slide. It says the partial agonist is less effective than other agonists. And then underneath it says can decrease their effectiveness when in competition with them for the same receptor sites. They're meaning the other agonists?
Yes. Okay. So basically a partial agonist can kind of fulfill the role as either an agonist or an antagonist in the sense that the partial agonist can block the receptor site, so the true agonist can't get on. But it usually is not quite as robust a response, so it's kind of like a weaker response, but it's still stimulating. So
I see.
Yeah, so in the sense of the absence of a true agonist, you would get a little bit of stimulation, but in the presence of a true agonist, you block that agonist's ability to bind. Where you see these used a lot are really in two arenas. One is in pain management, where you're trying to kind of modulate a response, where you're trying to get somebody a little bit of relief without having to give them a really strong drug.
Got it.
And then they also use them in smoking cessation drugs. So they kind of give you a little bit of nicotine, but not as much as if you had that kind of a full effect.
Okay.
So that's...
Okay, so just out of curiosity, when people, someone's taking a drug that's a partial agonist, and they also, let's say they're taking the partial agonist, for example, smoking.
Mm-hmm.
So they're taking the partial agonist, but then they go and light up and get the nicotine that way,
Yeah.
is it going to, it's going to block the nicotine's response or block the response from the cigarette?
It can. I mean, the nicotine effect. So they do compete because like they'll bind and they'll release. It's not like they stay there forever. So you do get, it's kind of jockeying for position, but while the partial agonist is on, you won't get that stimulation of the true agonist. But as soon as so you could like dump a whole bunch of nicotine in there, and that would bump those partial agonists off, and you'd flood the receptors.
The concentration's higher.
Right.
So.
Right. Exactly. Yeah.
Okay.
That's exactly right.
Got it. Okay. Trying to see what else I have here. And then is partial agonist covered under, that's considered competitive?
Yes.
So that would be a competitive. And
so yeah,
antagonist?
It acts kind of like a competitive antagonist. I mean, it's only an antagonist in that it's not letting the true agonist in, but because it does have a little bit, it's not an absolute blocker like a true antagonist would be, where it's just like parked on there and it's not providing any therapeutic effect. So you get, so in that sense, you kind of are, that's why we say they're kind of like an agonist and also an antagonist.
Okay.
And actually, in reality, oftentimes they refer to them as agonist antagonists instead of partial agonists. So it makes a little bit more sense when you look at it like that.
Got it. Okay. I was just wondering what it would, if it's classified as
yeah, it's competitive. Yeah, they compete for the same slot.
Right. Okay. Yeah. Your example of, is someone else wanting to ask a question?
I don't know if anyone else is talking. I'm going to type in the box here to tell them.
Okay.
Okay. Nobody's saying anything, so I think you're good to go.
Okay. Could you explain your example on, because I haven't gotten to this point in the video yet, the pentazapine, is it pentazapine, the tall example?
Oh,
it's like a chart right below the partial agonist.
Yeah. So that's a pain medication. So that's kind of what we were talking about there. So the partial agonist is, so the Demerol is the true agonist, the red line. Yeah, and the partial agonist is the Talwin. Mm-hmm. And so you see that you're not having the same amount of efficacy, but you still are getting a little bit. So it's occupying and it's, when you give Talwin, it occupies the same receptor site as the Demerol. Okay. So, I think I was just looking at it wrong. I was looking at it as if they were both being given like at the same time or something, but it's just showing the difference. Right. Yes. Efficacy. Yeah. Okay. Yeah. Because if someone's given Demerol, or if you're on Demerol and you give them a big hefty dose of the other one, then what's going to happen is the Demerol is going to get kicked off and the Talwin's going to get on there. Yeah. Okay. Yeah. That's what that's all about. Okay. And I'm sure that's why I'm trying not to like ask too many questions. This one seems like there's more content in this unit. Yeah, it does get a little bit more, and it's a little more challenging. So I'm just trying to, because I haven't gotten all the way through it yet. Oh, that's okay. It's fine. We're here. You may as well ask. Yeah. That's why I figured I would utilize it. I didn't really know. I've never done this kind of like video online. I know. I have not too much either. Okay. It looks like somebody is asking a question. It's Gina says she wants to talk about renal clearance. So clearance is kind of confusing and it can get pretty complicated, which we don't really need to do for this class. But essentially renal clearance is talking about the time it takes for the kidneys to eliminate the drug. And so it's calculated so clearance, and it doesn't necessarily have to be drugs. They calculate all sorts of clearance, like creatinine clearance is how, so it's like how much creatinine you can get rid of in a unit of time. And why that's kind of important for us in this particular class is it gives us an idea of how long a drug is going to be hanging around. So it helps us to kind of understand that. I'm trying to think what else might be helpful there. I don't know if that helps you, Gina, or if there's more, if you want me to say something else. I can't remember where clearance is discussed in.
Yeah, is that under drug elimination? I don't
Yeah, that's where it should be. Is that in Unit 3?
Yeah, so on slide 53, it's saying excretion.
Yeah, it's
but I don't see renal clearance on the slide. I see excretion.
It might be in the half-life part. Let me see here. Gina, if you can hear me, can you tell me what unit that's in? Oh, Unit 3. Yeah, it is in Unit 3. Okay. So let me see here. Let me pull that up.
Yeah, I haven't gotten there yet.
I think it's towards the end. I have another, I forgot my book on my desk at work, so I'm trying to go through the slides myself. Oh yeah, it's got to be kind of towards the end, I think, after the ionization business.
Oh yay, I got it!
Oh, there you are. Oh, good.
Yeah, like the whole time I was like, how do I turn it on?
There you go. Okay, I'm looking for that, Gina, for you.
It's under.
It's towards the end of that whole thing,
Yeah.
isn't it? Oh yeah, it's on. Oh, here it is. Yeah. Okay. So yeah. So that's basically. So it's clearance is kind of a big topic, and it's very vague, and it's just the amount, how much time it takes to clear a known volume of something from the blood into the urine, and so it's calculated, and there's different kind of ways to think about it, but in terms of drugs, we basically use it to estimate how well someone's kidneys are functioning. So the reason why it's kind of important in terms of pharmacology is because most of our drugs are eliminated through the kidneys. And if somebody's kidneys are damaged, then if damaged and it's a drug that's eliminated through the kidneys, which are most drugs, then we know that that drug is going to stay around in their blood, potentially active for a longer period of time. So that's essentially how it's used in a clinical setting. It's used to estimate somebody's renal function. So if let's say you're going to give somebody a drug like lithium, for example. Lithium is used for people who have bipolar disorder. And we know that lithium is really hard on the kidneys. That's like one of the things that is known about lithium. So before you administered that drug to that patient, you would want to know something about their renal clearance, because you'd want to make sure that they're going to be able to under the best case scenario, they're going to be able to clear that from their bodies. Does that make sense?
Yes, thank you.
Yeah, it's kind of confusing on the slide because it talks about how physiologists talk about it and how clinical people talk about it and how research people talk about it. So in research, that's kind of how we come up with dosing strategies, is based on that information that they gain through research, to be like, oh, this thing doesn't clear that effectively, so we don't want to give it to somebody like every 3 hours. We want to give it every 12 hours or something along those lines.
Okay, thank you.
Does that make sense? Sure. What about, I'm not sure if Jess and Grace can hear us. If they can, then you could type in the box. We can't see you. How did you make it so we could see you? Is there a button somewhere that?
Yeah, so I was going through like the bottom. It's like a little sidebar that pops up, and then it's like the little microphone button, and then it has like a little video.
Oh, okay.
Icon, so you just click on that.
Oh, that's how you do it. Mine, it just came straight up, so I didn't know how you guys did it.
Yeah, I have a MacBook Air. and it just, when I joined the meeting, it just popped right up
automatically. Yeah, I have a Mac too. I think Macs kind of do that naturally.
And then I had another question, like on the end of video 4, you asked the thought question, the one that says, what factors determine a drug's onset, peak, and duration? I wanted like just to check on that to see if maybe I got them right.
Okay, so tell me what you think.
So for all 3 of them, I think binding to plasma proteins have to do with it.
Yeah, that's definitely part of it.
And then for onset, I thought also maybe like the route of administration.
Yep.
And then also time for onset. I'm not sure about that.
So time for onset would have a lot to do with, so basically what we're trying to think about is like what kind of individual patient variables might alter the way the drug is going to act. And there's like millions of things you could say about this. One is you could think, well, first the question is, are they going to actually absorb the drug? So that would be one question. Like, let's say it's a drug that you give orally and they've got like Crohn's disease or something, and they've got it, or they have celiac disease, or they've got a super inflamed small bowel. So that wouldn't work. Then you would expect that not to work as effectively for them. Then you can also think about like their circulatory system, whether or not they have enough, if their blood flow is adequate enough to actually pump that drug around. Their kidneys, of course, in terms of being able to eliminate it. Their liver in terms of their ability to metabolize the drug, those kinds of things. But yeah, also things like plasma protein binding, like you got to kind of consider that when you're thinking about, especially adding drugs to the regimen. Like if you're going to add an additional drug, you got to kind of think about plasma protein and all of that kind of stuff. So that's kind of what I was hoping, that you would just be able to sort of think about potential factors that might make a drug not work in the way potentially that you expect it to, or in some cases make it even more effective, and then there's the whole whole genetics situation, which we're just learning about, where some people metabolize drugs too fast, other people too slow, or not at all, that kind of a thing. Did that make sense?
Yeah.
Okay. You guys, I'm going to stand up for 1 second and give my dog something to eat because she's whining.
It's okay.
Okay, sorry about that.
Was that the question on the thought question?
Yes.
Is that what it was pertaining to? Okay.
That's at the end of, that's the one that's on slide 64 on the third presentation. It's at the end of the 4th video, but on the slides, it's on slide 64 of the 3rd unit.
Oh, got it.
Yeah, so onset has a lot to do with actually absorbing. Peak has a lot to do with metabolizing, and also just getting the drug there. And then the duration also has a lot to do with metabolizing and then eliminating. Those are kind of the big things to think about. Mm-hmm. So you want to kind of, in a practical sense, that means like patients that have cardiovascular disease, you're going to think about that on maybe onset and peak. People that have liver and or kidney issues, you're going to think about that a lot with duration, peak and duration, that kind of a thing.
Got it.
Because you can't really anticipate a drug doesn't always act the way it says it's going to in the book, because the person has other things that are going to complicate that.
Got it. That's what you're talking about, the onset, having issues, like if you have Crohn's disease, it wouldn't allow absorption.
Absorption is a big issue. Yeah, a big issue for that.
Okay.
All gastrointestinal disorders really get in the way when it comes to absorbing drugs.
Right.
Mm-hmm. Which then means that it can continue on, because if you don't get enough of it in, then it's never really gonna actually maybe potentially even get above that minimum effective concentration. So the drug might not ever peak at all, So on a test, like if I ask you a question, like you give this drug to 4 different people, and depending on what I would ask, but you would think about like the liver's going to make it so they don't metabolize it, the kidneys are going to make it so they don't potentially eliminate it, and the GI is going to be that they don't absorb it potentially.
Okay. Got it. I had a question actually about, so I haven't made it this far in the videos, but I've looked at the slides. The last thought question, what would you change for each drug to make both meds more safe and effective? So the competition for plasma proteins.
Okay.
Is that, would you say like making them both have equal binding affinity?
So
Would that be something?
So when you've got a plasma protein binding situation and you're using more than one drug, it's not such a big deal when you're only using one drug. When you add other drugs, though, it becomes a potential problem. So basically, in that example on the slide, we say that we have two drugs. We start with drug A, which is plasma protein. And so the thing that confuses people sometimes with plasma protein binding is that the job of the plasma protein is really just to transport the drug around. It's like a shuttle. Yeah. So the plasma protein's just shuttling that drug around until it can be released to go to its receptor. So when you're just talking about one drug, oftentimes the benefit of plasma proteins are they can kind of act like a built-in sustained release, kind of a controlled release sort of a situation. So oftentimes they'll give like a good example of drugs. There's a lot that are plasma protein bound, but the classic example are a lot of the anticoagulants. So you give a big hefty loading dose. So you're going to set somebody up on an anticoagulant. You give them a big loading dose, and it's a big dose, but it's not going to be very effective at the receptors because it's all going to load onto the plasma proteins. And then the plasma proteins will slowly release it over a course of, let's say it's every 12 hours. So over the course of those 12 hours, the plasma proteins are going to slowly release that anticoagulant. So you're getting a steady supply of anticoagulant to your receptors. Does that make sense?
Okay. So it's being released to the receptor.
Yeah. So
whatever action.
Right, in a kind of a controlled
like
way.
Blood thinning.
Blood thinning. Exactly. Yeah. It's
so
to
that
keep.
way it's not like your blood. I mean, because you could bleed out if it's just
Exactly. Precisely. Yes. So.
Okay.
So that works great. And then somebody's got their anticoagulant and they're doing fine. And then all of a sudden we're going to give them another drug because they need to have more than one drug. So then we add the second drug to the regimen. And this particular drug is also plasma protein bound. So the plasma proteins can really only hold on to one drug. And they're going to hold on to the one that they have a stronger affinity for. So if the second drug if the plasma proteins have a stronger affinity for the second drug, then all of a sudden that first drug, the anticoagulant, is going to be dumped out of the shuttle and the new one's going to load on. So now all of a sudden you have a whole shitload, pardon my expression, of anticoagulant in the blood free, and it's going to bind all those receptors, and then somebody like cuts their toenail and bleeds to death. Right? So that's the deal. So in the thought question, how you make it more safe is you would have to consider which one's more highly plasma protein bound, and you would have to kind of anticipate if I'm going to give them a drug that is going to bump this anticoagulant off of the plasma protein. You want to make sure that you've given them enough time to release that anticoagulant. It's not like they stay on there forever. They stay on there, they slowly release it, let's say over the period of 12 hours. So you'd want to wait until you're at the tail end of that dose. And then you would want to give them not a huge dose of the second drug, because you don't want them, you want them, so you give them kind of a small dose of the second drug and kind of titrate them up while you're sort of titrating them down on the other one. And instead of giving them big loading doses, you're just giving them small maintenance doses.
Got it.
Does that make sense?
Okay, so less. Okay, I was thinking more like abstract, like if we were able to make both of the drugs like equal in their binding affinity.
We can't do that.
That's different. Yeah, you can't do that.
We can't change physiology, unfortunately. So all we have to do is work with
Right. I didn't really. I mean, I haven't looked at the video yet. I was just kind of thinking.
It's
like,
that's not. It's a hard concept. That one's a hard concept to get. It's a hard
Okay.
concept to get.
But yeah, you explained it well just now. So okay. I think that's it for me right now. I may have a question from earlier. I just need to check.
I'm gonna look on.
So does that kind of relate to like the questions that are in the book, like, right?
Yes.
Here?
Yes. Yeah. I can't see. What do the questions say?
It says during the run-in phase, how will one priming doses and or two maintenance doses for both drugs need to be modified in the following two cases? When the first drug given binds more tightly to plasma proteins, and then the next scenario is when the first drug given binds more weakly to plasma proteins.
Yeah. So in the first one, when the first drug binds to more strongly to plasma proteins, then you need to just know that if you give it a lot of it, it's going to dump all that the drug that was on before. So you'd want to give small doses of that new drug that has a higher affinity, and you'd want to give it after you're reasonably certain that you've unloaded a fair amount of the drug from the plasma protein. The second one, if the second drug has a weaker affinity for the plasma protein, then you have to think that it's not going to get on the plasma protein. So you'd want to give it in small doses to begin with. You wouldn't want to give the big loading dose, because the loading dose is so hefty because we know that most of it's going to get stuck on plasma proteins. Very little of it's going to get to the receptor. So if those receptors are occupied and that drug that's occupying those receptors on the plasma protein aren't coming off, then you'd want to make sure you don't give a big dose of that new drug, because it's not going to actually bind the plasma proteins. It's going to go straight to the receptors. Does that help?
Yeah.
Okay.
Thank you.
Those are good questions.
So just to like repeat what you said, just to make sure that
Sure.
I got it. So like for the first scenario, if the first drug given like binds more tightly, so you don't want to give like a lot of it, like you were saying, right? You want to give like a smaller dose so that you give it enough time to like do its thing.
Yes.
Like, so, yeah. Don't overpower it.
Yes.
And then the second scenario, if the second drug is the weaker one, you still want to give a small dose, because even if you give like the higher one, the receptors are already occupied by the one that has higher affinity, right?
Yes, exactly.
Okay.
Yeah, exactly.
Thank you.
Sure. Do you guys understand sometimes people get hung up on the controlled substances versus the regular prescription drugs. Does that make sense to you guys?
Yeah, I think for the most part, it makes sense. I'm looking over that right now. I feel like Unit 2 is I'm pretty confident about Unit 2.
Yeah.
But
One thing that people oftentimes kind of get messed up is the fact that, so when you're doing the whole drug design, thank you, the drug research and all of that, and that's when they're evaluating all that data, that's basically when it's determined where the drug is going to go, whether it's going to go on the schedule, whether it's going to go as a regular prescription, or we call them legend drugs. In California, they're still prescription. You still have to have a prescription. They're just not controlled substances. So people sometimes confuse that, thinking like just because it's not a controlled substance, it's not a prescription. But it is still a prescription. It's like oral contraceptives or antibiotics. So no one's going to get addicted to those things, so there's prescription, but they're not scheduled. And then there's whatever is going to be over the counter. So the thing to remember is that all drugs, it doesn't matter if it's going to sit on the shelf at CVS, it's going to be a controlled substances or a substance or a legend drug. They're all going to start off in the research, trials. They're all going to start off as Schedule 1. Then at the end of that, then the Attorney General of all people, why that person, I have no idea, but decides where they're going to put these things. So if they decided this drug is a controlled substance and it's going to be available to actually dispense to people, it's going to be 2, 3, 4, or 5. 5 is a little confusing because in some states, like Arizona, for example, you can get a Schedule 5 drug from the pharmacist. But so people want to make that over the counter. It's not the same. The pharmacist does not put it on the shelf. You just have to go to the pharmacist and they give you all the information. They keep the records and they're essentially writing the prescription. In California at this point, which will probably change soon, we don't do that. You have to go to a physician to get somebody who has the prescribing right for that.
Yeah, because for controlled drugs, they have to keep a log.
Right. Exactly. It's supposed to be theoretically
dispensed.
Yeah, exactly. How many to whom and all of that. And it's all put into a database and they're theoretically tracking it. It doesn't seem like that's really happening, but that's theory what's happening. So anyway, that's one thing that screws people up is they get confused between Schedule 5 and over the counter, and they get confused. So an over the counter drug, once it's designated over the counter, at that point it's over the counter. Like it's not anything. It's over the counter. That's something, for some reason, that sometimes throws people out the window. I don't exactly know why, but you guys seem like you get it.
Yeah. One question about that though. So like certain things with like, I know in California, I don't remember when this happened, but like cough syrup or like certain amounts of that were pulled from over the counter. Right. So I know you just mentioned once it's over the counter, it's over the counter. But so there's occasionally an exception.
Well,
depending on, like that considered use, or would you consider it?
Oh yeah, the story with that is those it's like Sudafed, for example, or something, anything that has diphenhydramine in it. So there's all sorts of things you can get. And so apparently, I mean, I don't know exactly the recipe or anything, but I'm sure you can find it on the internet how to make some kind of meth or whatever from your combination of like Comet and that stuff, and who knows what else you put in there. But so people were going in and buying like shopping carts full of Sudafed and anything that had diphenhydramine on it. So somebody finally said, like, we got to stop this. So they regulated how much you can purchase, but so they stuck that behind the counter so they could say you can only buy 2 bottles or whatever. I don't know exactly. Right. I'm sure somebody in our class works in a pharmacy, so they know. But I think it's like 1 or 2 bottles. I mean, nobody needs 10 bottles of Sudafed at one time, right? So, so it's still an over the counter. So it's confusing because it's still over the counter, but they don't keep it, out next to, whatever else you can find at CVS, which is pretty much everything.
Like handfuls at a time. Yeah.
Exactly. So they won't let you purchase more than I don't know. I think it's 2, but I could be wrong about that. So that's confusing because that's where people kind of get, I think why people are confused is because it's like, well, it's behind the counter and you have to talk to the pharmacist. So we want to make that a scheduled substance, but it's not scheduled. It's still over the counter because if you take it the way you're supposed to take it, it's safe and not dependence causing. But when you mix it with all that other stuff, it's a whole other story. So that's the problem with that. Okay. But it's still technically over the counter.
Okay. Yeah, I just, out of curiosity, like I just remembered, I mean, it's kind of maybe a little bit off topic, but last time I bought some type of like NyQuil or I don't even remember, they checked my ID and everything like that.
Yeah, they're kind of locking down on that. Exactly. Yeah.
I don't know if that was just like for a period of time.
I think it seems to have relaxed a little bit, but and I don't know, it might be different in different demographics. Maybe there's different places where they're in
that's interesting.
Yeah, I'll have to ask
how they regulate
how they figure that out. And I don't know. Somebody probably listening, I'm sure somebody works in a pharmacy. I don't know what they, in terms of record keeping, like what they do with that information exactly. But yeah, that was the problem with that.
Yeah, I was just curious. Sorry, it's not really.
No. I think I'm glad that you brought it up because I think that's what stems some of the confusion because people do know that, and so it's like, what's happening with this, you know?
Yeah, they like make an association because of that.
Because you have to deal with the pharmacist. Exactly. Exactly. I'm trying to think of what other things people get confused about.
I have a question on the sample questions for Unit 3. The one with like, with number 7, that says like special cautions must be taken with blank when administering drugs because hepatic and renal systems are often not operating at full capacity. Answers it's only infants, and then see aged individuals. So like weight wouldn't like be a factor in that. It would just be strictly age for that specific question.
So read the question to me again. I'm sorry, I don't have the book and I couldn't hear you.
You're good. It says special cautions must be taken with blank when administering drugs because hepatic and renal systems are often not operating at full capacity, and the choices are overweight individuals, infants, aged individuals, all the above, or only B and C, which is infants and aged individuals.
And the answer is B and C, or just C? Yeah, B and C. So that with small people and very little people and very old people, with little people, their systems aren't quite mature enough yet, and so they have a hard time metabolizing and clearing certain drugs. There's some that are worse than others, and then the flip side, so they're just not developed enough yet. On the elderly side of things, just a sad thing about aging is organ systems tend to become less efficient, and as we get older, and so they tend to have problems clearing them for that reason, metabolizing and clearing. So we really worry. The overweight the issue with people who are overweight have a lot more problems with drug distribution, because drugs that are fat soluble, which many of them are, will distribute they'll distribute widely. They'll go wherever, and wherever you have a lot of fat, we tend to move a lot of drugs into that compartment. And once they go in, it's sometimes hard to have them come out again. So that's the issue. So that's more about distribution with the overweight people. But it's with kids, infants, and elderly, it's more about metabolism and elimination.
Thank you.
Sure.
Okay. So just to clarify, sorry, I got a little distracted.
That's okay.
Overweight,
It's
I'm
a
just
distribution.
thinking about like drug tests. It like stays in your system for a longer period of time, but you aren't worried about metabolizing it.
No, it doesn't even. Yeah, exactly. It just gets like sucked right into the fat. Exactly. So like it's kind of a problem because and it has to be a fat soluble drug. So which, like all the CNS drugs are of course fat soluble because they go to the brain. This becomes a really big problem when we're trying to deal with anesthetic, because the anesthetic is super fat soluble, and it goes, so people who do that, there's a reason why anesthesiologists make so much money when they don't seem like they're doing much of anything at all, because, they're just sitting there and they're raking in like tons of money, and they have to know what they're doing clearly, and and the patients they hate more than anything are people who are really overweight, because it's really hard to keep the anesthetic in their bloodstream, so they actually go under and stay under because it just wants to distribute into their fat.
Yeah.
And people, and on the flip side of that, people who have a lot of fat, oftentimes if they lose weight, they'll start releasing drug into their
drug. Yeah, I was going to ask about that. They release it into their
they'll release it into
bloodstream.
Yeah, and it's kind of hard to control in that case too. So it's a tricky situation with those fat soluble drugs.
Okay.
So it's all about distribution for those people.
Got it. Distribution. Okay. Versus metabolizing for infants and aged individuals.
Yeah. And then, of course, anyone that has kidney disease or liver disease, you're going to think about metabolism and elimination.
Okay.
liver disease makes drug administration really tricky because they have a really hard time metabolizing drugs. Some drugs get activated in the liver, not as many. Most of them get metabolized in the liver, but either way, you're going to have an issue with somebody that has liver problems. So we have to be really super cautious with those kinds of patients.
I have a question, but this is kind of like back to unit 2.
Sure.
For the sublingual and then buccal.
Yes.
I think you said that 4 drugs destroyed by liver or digestive enzymes, which makes sense, like I need to be there. But then you also said you don't chew, swallow, or take water, and the reason being is because you just want it to stay within there, right? You don't want it to go like, ooh.
Right. Yeah, if you take a drug, if you administer a drug sublingually, you want it to be absorbed into that vascular bed under your tongue. So it's going under the tongue and it needs to stay there. The minute they swallow it, like it happens a lot. Like nitroglycerin, for example, is a drug that can be administered this way. And so you give somebody nitro and you tell them to take it under their tongue, but they're not paying any attention to you and they're swallowing it every day just because it's a pill. And they're like, oh, I'll swallow it. It's not doing them any good because it's no longer sublingual. And same with water, because water will diffuse. What's the word I'm looking for?
Dissolve?
It's sort of dissolve, but I was thinking of, I guess dissolve is good. I'm drawing a blank for the word I'm looking for, but it decreases its concentration. It spreads it out, right?
The osmosis?
Yeah, like diffuses, I guess. It doesn't really matter, but you get the idea, right? And so half of it washes away, and then they swallow it. And the buccal's more, the only profession that really uses a lot of buccal are the dentists. Yeah, so that's where they do lidocaine and all those injections for numbing your gums and your teeth and stuff. I can't think of an example of a non-dental use for a buccal administration. I mean, I'm sure there are some I'm drawing a blank on, but that's like chewing tobacco, right? That's how they do that. They shove it in there and it sits there, which we're not going to do because it's not good for us.
Oh, and then also for the therapeutic equivalent, so this is like a completely different drug, right? It's not really
therapy. Yes. Oh, yeah. That's something that people get confused on. Yeah. So the therapeutic equivalent is a completely different drug. It is it's designed for the same therapeutic use. So for example, and where this becomes an issue is like in hospital settings or in like managed care, maybe a nursing home, that kind of a thing, where the establishment has a formulary that they work off of. And the formulary, they have certain drugs that they give. And so somebody comes in with let's say they have some kind of a bacterial infection and the antibiotic that the physician recommends is not on the formulary. But so they can go to their formulary and they can choose a drug that would be appropriate for that same kind of microbe. Like if it's gram-positive, they could choose another antibiotic that would be effective for a gram-positive, but it could be a totally different antibiotic. It's not a generic at all. It's just it has the same therapeutic use. So the way to get around that is if the person that's doing the prescribing wants that specific drug, then they have to specify that on their prescription, that they want it to be dispensed as written or no substitutions or something along those lines. And if that's not specified, then in those kinds of settings, they don't have to ask if they can swap them out. Oftentimes they will say, hey, this is what we've got. Is this okay? But it's not required. And the difference between a generic, just since we're talking about this, how a generic is different is a generic is the same active ingredients as the drug that was prescribed, but the inactive ingredients can be different. And it's obviously cheaper because the drug is off patent at that point, or there wouldn't be any generics. And the drug company that produces the generics don't have to put all that research in, so it doesn't cost them very much to bring these drugs to market, versus the companies that do all the legwork and they get these drugs to market. It costs them, in the neighborhood of, who knows, $20 million, I think is the pretty much average. It's a huge amount of money. So they want to recoup all that money back as soon as they can. So they charge a shitload of money for it until their patent expires, which is usually 17 years from the time that they started investigating that drug. So in some cases that could only be like 2 or 3 years they have to recoup all that money. And then we can bring generics to the market and they can be, a fraction of the price. And theoretically they're the same drug, the same active ingredients, everything's the same. The things that are different are the inactive ingredients, like the binders and the fillers and the dyes and all the carnauba wax and the stuff they put around the outside of the pill. That's all different, or can be different. That's not regulated, but the active stuff has to be the same. So if the drug, and in many cases the generic doesn't perform in that person the same way as the brand name drug did, it's not because of the active ingredients. It's because something else in that drug is maybe getting in the way of them absorbing it, or they might have an allergy to something that's in there, or, something along those lines.
Okay, thank you.
Sure.
And then for off-label use, you're using that same drug, right? But it's for something that it wasn't tested for.
Exactly. Yeah, so and that happens a lot. A drug comes to market and people start taking it and it's like, oh, well, it seems like it's helping this totally different condition. And so they can start to use the drugs off-label. And if someone's using a drug off-label and they're using it frequently, it's usually listed in the drug books. They'll say at the bottom, at least for the drugs, facts, and comparisons, they put a little paragraph that says off-label usage, and they'll tell you what people are using it for.
Thank you.
Sure. Let's see what else. I'm trying to think of other things that are usually a little bit confusing for people. The drug allergies, did that make sense to you guys? Oh, you might not have gotten that. It's at the end. So drug allergies and idiosyncrasies is a little confusing. A drug allergy is something, is basically unique to the patient, and they don't have to have very much of the drug in order to have a reaction. It can just have a little bit and have a pretty strong reaction. We kind of have a pretty good idea which drugs people tend to have allergic reactions to, where idiosyncrasy is like a completely weird thing that it's not you can't really anticipate it whatsoever. Side effects, like a side effect and an allergy are different. Side effects you definitely can anticipate. Anticipate. That's something that's a little bit weird, but I guess that's not that confusing.
So you can anticipate those, you said?
You cannot. The idiosyncrasies are, you can't.
Oh, okay.
Yeah.
No, I mean the side
effects. Yeah, the side effects you can anticipate. We know that. And the allergies, you can't really anticipate, but once somebody has an allergic reaction, they're always going to have an allergic reaction to that drug, I guess is one way to think about it.
It's like the memory cells
exactly
in the body.
Yeah, and then even if they get a tiny bit of it, they'll have like a really crazy reaction. So Grace wanted me to talk a little bit about half-life. So half-life's another thing, kind of like renal clearance, which can be really complicated, and we don't really need it to be complicated. With half-life, basically, half-life is telling us, again, how long you would expect to have that drug hanging around. So all drugs get degraded over a period of time. From drug to drug, that's going to be different. So some drugs are going to have a long half-life. Some drugs are going to have a shorter half-life. What the half-life is basically the time it takes for that drug to be metabolized 50%. So for roughly 50% of it to be gone. So at the end of the first half-life, you would expect the drug to be about 50% gone, give or take a little bit, keeping in mind that there's, people are different and all the like cardiovascular stuff we talked about, liver, kidney, all that stuff. So each half-life, 50% of whatever drug was remaining will be gone. So let's say we administer a drug that has a half-life of 8 hours. At the end of 8 hours, you would expect 50% of that drug to have been eliminated. At the end of the second half-life, which would be 8 hours later, you would expect 50% of that 50% that you started with to be gone. So essentially 75% of the drug should be eliminated. At the end of the third half-life, which would be 8 hours after that, you would expect 50% of that 25% that was there. So, 12.5% roughly. At the end of the, how many was that? Fourth half-life, 50% of that 50%. At the end of the fifth half-life, you can pretty much, provided that you only have administered that drug one time, you can pretty much count on that drug being pretty much gone. So it takes 5 half-lives to clear a drug completely from, and keeping in mind that, of course, if they have liver disease or something, that would be maybe a little bit different. So that's why we don't get too crazy about like being real specific about the half-life. So you kind of edge on the cautious side of things. So, but you can safely say that for all drugs, if you're administering them one time, a single dose, by the end of the fifth half-life, that drug should be eliminated. So some drugs have a half-life of 15 seconds, like ketamine, some of the gaseous anesthetics. They're in, they're out, gone. So 15 seconds, by a couple minutes, that stuff is gone completely. Other drugs, like some of the CNS drugs, have half-lives of like a couple days. So they're hanging around for a long time. So the utility of understanding the half-life gives you an idea about, well, how often do I want to give this thing? Provided you're dosing them more than once. Dosing strategies are based on the half-life. So when you are administering a drug that says you need to give this drug to this person every 4 hours, you're basically dosing them on the half-life. So you're giving them their second dose at the end of the first half-life because you're trying to keep the drug concentration above that minimum effective concentration. If you take them every 2 hours, you give it every 2 hours and you're supposed to give it every 4, then that drug is going to continue to accumulate in the blood and it could get to toxic levels. If you decide, well, I'm going to save my money and I'm going to take it every 8 hours rather than every 4 hours, then you're potentially never actually getting into the window where it's going to be effective. So it is kind of important to think about actually administering the drug, which seems to go without saying, but to administer the drug as it's designated to be administered. One other thing about the half-life is if you are administering a drug, chronically, like a blood pressure medication or something like that, where they're going to be on it for a while, you can expect by the end of the fifth half-life, or the fifth dose, you could say, that drug has reached what we call steady state, meaning it doesn't really move around too much. It doesn't go above into the toxic range, and it doesn't go below the minimum effective concentration. It stays bouncing around in that therapeutic window. So that's kind of helpful. So that's what we call steady state. It's not flatlined, but it goes up and it goes down, but it goes up and it goes down within that effective zone.
And that's each time that you give a dose after that 5 doses.
After the fifth dose. So if you're giving a drug chronically, after they've taken it 5 times, provided that they're doing it the way they're supposed to. So if it's they take it every once a day, by the 5th day you would expect that drug, provided they keep taking it, to stay at steady state.
Got it.
And if you give it only once, you would expect in the same context, let's say you give a drug that has a 1-day half-life, and you're only giving it once, by the 5th day you would expect that drug to be cleared from their body effectively. Yeah. Did that help you, Grace? Yeah, that responded back, so hopefully it did.
In your Unit 3 video, did you define, or maybe it's in the book, I didn't even check yet, the teratogenic effects? In Unit 3, the adverse effect or adverse responses to drugs? Is that something that we should just be able to define?
Yeah, that's more of just a definition.
Okay.
Yeah. We'll talk about some of that later on, in more detail later on.
I have a question for the study or the exam review that you provided. Everything that's on there is what we're going to be tested on. Like, do we need to know like other stuff?
No,
or just
stay with the study guide.
Okay. And do you suggest like just filling it out and reviewing it, or is there something else you suggest like reading for the exam?
I would fill it out and review it, but like you want to kind of know it at some level of detail, right? It's like you don't want just like one word answers. You want to be a little bit conversational around it, like to be like, oh, I could. If you feel like you could kind of explain that to somebody, you're good.
Okay.
Yeah, there is a little bit of kind of conceptual sort of critical thinking aspects to a lot of this. So that's kind of what you want to be able to do. I think you guys seem like you're in pretty good shape.
Thank you.
Mm-hmm.
Yeah, that's good to know because I don't feel like it right now. Yeah, it's almost bedtime.
Oh, also, this is not a question, but I noticed on the end of video, was it 5? Like towards the end, when you were describing like the plasma protein, like the sound went like choppy. It was like kind of like, I don't know, robotish. I don't know if it was just my computer or if like other people like heard it that.
It could have been my microphone. Sometimes that happens. When did that happen?
I think it was at the end of video 5. I know I watched it today. It was when you were talking about like the plasma proteins with the receptors. And
Oh,
stuff.
no.
It was like the last 3 minutes, I think.
Oh, really? Oh, shoot. I'll check it. And if it's bad, I'll try to re-record that last little bit. Yeah, sometimes I used to use, there was a microphone I was using and then I stopped using it because I recorded like a whole video and the whole thing sounded like Darth Vader. And so that was my microphone. So I got rid of that one, but it might've been in that same before, because I listened to them in the beginning, but I don't, to make sure that they sound okay. But if I don't, wouldn't have listened all the way through. So that could have been mine. So I'll listen to that. And if it's bad, I'll re-record that little bit. Nobody else said anything about it, but that doesn't mean it's not a problem.
Mm-hmm. Wait, which one was that?
The plasma proteins. She said the end of, it was probably the end of Unit 3, end of video 5.
Oh, I haven't gotten there yet. Okay, that's the last video?
I think so, yeah.
Okay. Yeah,
I'll check that out. The plasma protein slide? That's what she said, the plasma protein bit. So we kind of talked about it already.
Yeah, we did, yeah.
But it's nice if everybody could hear it.
Some small throat Yeah. Well, we're gonna keep doing some sort of video chat with our whole class here, and we're gonna try what they've all said, and we're gonna attempt to eat some sushi. So one of us should be.
Yeah, it was the last one, like at the 6-minute mark. So it was like Unit 3, Video 5, Adverse Reactions, and yeah, like at the 6-minute mark, it just started going like.
Oh no. Unit 3, Video 5, 6-minute mark. Okay, I'll look it up. Thank
Yeah,
you.
it's like 6:30, like when it started. Like you kind of started, but then like at 6:30, it was just like. Ugh.
Oh, that's terrible. Oh, shoot. It's funny, nobody said anything about that to me.
Yeah, that's what I was like. I don't know if it was just my computer. That's just like that's why I put the captions. But it kind of helped. That's why I wanted to ask like today on the live chat that question. Which you did.
Yeah, I'll check it out. That doesn't seem, that's bad.
I'm 168 9. So I'm skinnier than I've been in years.
I think that's all the questions I have.
You're good? Okay. Well, I might schedule another one of these for early in the week for any last, since the test you'll have from Monday to Friday to do. So I might try to do, I might try to shoot for again Wednesday because I teach Tuesday night late. So maybe I'll try Wednesday one more time, or even Monday. I could do Monday night. One of those two. All right.
Okay, yeah. Thank you so much.
Oh yeah, sure.
Really,
No problem.
really helpful.
No problem. All right, you guys. Well, I'll talk to you soon.
Thank you.
Okay.
Have a good night.
You
Thanks
too.
again. Have a good
Bye-bye.
night.
Bye.
Bye.